Welcome to Board Pearls. This is episode 3 of 4 of the biliary tract disease chapter in the pancreatic and biliary disease module. This episode is the stone in the bile duct, the probability framework that decides who goes straight to ERCP, and acute cholangitis, where the same stone turns septic and the timing of decompression becomes the whole management. Start with stones in the duct because the whole problem sits on a probability question. ERCP is a useful procedure with an unfriendly complication profile headlined by post-ERCP pancreatitis, which is common overall and climbs much higher in young women with a normal bilirubin and suspected sphincter pathology, and that risk is why the framework is tiered. You earn the right to do an ERCP by raising the pre-test probability of a stone high enough that the procedural risk is justified. The framework divides patients into 3 tiers: high probability above 50%, intermediate at 10 to 50, and low under 10, and the tier dictates the test. High probability requires any one of 3 features: a stone seen in the duct on imaging, clinical ascending cholangitis, or a bilirubin over 4 with a common bile duct dilated above 6 millimeters in a patient who still has a gallbladder, and any one of those sends the patient straight to ERCP because the probability of a retrievable stone justifies the risk. Intermediate probability is everything else that looks suspicious, meaning any abnormal liver chemistry without a high-tier feature, a dilated duct without a visualized stone, or age over 55 with biliary pain. And these patients should not go straight to ERCP because a meaningful fraction won't have a stone, and the procedure becomes an empty risk, so the right move is to confirm or refute the stone first with MRCP or endoscopic ultrasound. The choice between those two is itself a teaching point. MRCP is non-invasive and images the whole biliary tree without sedation but misses small stones under 6 millimeters because its resolution can't reliably catch microlithiasis or sludge, while endoscopic ultrasound brings the transducer within centimeters of the distal duct and catches the sludge and tiny stones MRCP misses. So when the question is small stone or sludge disease, endoscopic ultrasound is better, and when it's an anatomic survey of the duct, MRCP is fine. Low probability is none of the above, with normal chemistries, normal caliber, and no red flag. And these patients go to laparoscopic cholecystectomy without preoperative duct imaging, adding intraoperative cholangiography selectively if the anatomy prompts it. There's a subtlety even inside the high probability tier, because only a majority of high-risk patients actually have a stone at ERCP, so some endoscopists still run an MRCP or endoscopic ultrasound even on high-risk patients to avoid an empty procedure, accepting a small delay to spare a stone-free patient the pancreatitis risk. And while the evidence doesn't mandate that pre-ERCP imaging, the logic is consistent with the rest of the framework. Take the young woman with 2 episodes of right upper quadrant pain after fatty meals, febrile, with a bilirubin of 1.6, mildly elevated transaminases, an alkaline phosphatase around 165, and a common bile duct of 8 millimeters without a visualized stone. She sits squarely in the intermediate tier, and the temptation is to send her to ERCP because the duct is dilated and the enzymes are abnormal, but that's a mistake because she doesn't meet a high-risk criterion, so the right next step is MRCP, or endoscopic ultrasound if you suspect small stones. 2 more wrinkles before leaving duct stones. First, stones in a post-cholecystectomy patient follow a clean 2-year rule, where stones within 2 years are usually retained from the original gallbladder, while stones beyond 2 years are usually new brown pigment stones formed inside the duct under stasis and bacterial deconjugation. So a patient returning 3 years out with a duct stone has a shifted etiology, and the bioleak framing is wrong. Second, large stones, anything a centimeter or larger, are hard to extract through a conventional sphincterotomy, because a sphincterotomy can only enlarge the opening to the diameter of the intraduodenal duct and cutting further risks, perforation or bleeding, so a centimeter-plus stone hits that mechanical limit. And the first-line therapy is sphincterotomy plus large balloon dilation, which radially stretches the orifice without cutting further, with cholangioscopy-directed lithotripsy that fragments the stone under direct vision. That moves to cholangitis, where the stone has the same biology, but the patient is septic, and the time pressure is different. Cholangitis is ascending bacterial infection of an obstructed biliary tree, and the mechanism that matters is hydraulic. Stagnant bile colonizes with enteric organisms, then the obstruction raises intraductal pressure above the pressure in the hepatic sinusoids, and bacteria and endotoxin reflux from bile into the bloodstream, which is why cholangitis turns septic so fast, and why antibiotics alone can't fix it, because they suppress bacteremia for a while. But the closed obstructed duct keeps receding, so the central intervention is decompression. The Charcot triad of right upper quadrant pain, fever, and jaundice is present in only about half to two-thirds of cases, so the absence of the full triad doesn't exclude the diagnosis, and the Reynolds pentad adds altered mental status and hypotension to identify the severely septic patient already failing organs. The Tokyo grade sets the severity and the timing. Severe disease is defined by any organ dysfunction, cardiovascular changes needing vasopressors, neurologic changes, a respiratory oxygenation ratio under 300, a renal creatinine over 2, a hepatic INR over 1.5, or a hematologic platelet count under 100,000. Any one of those needs biliary decompression within 24 hours. Moderate disease requires any 2 of 5 inflammatory criteria: a white count above 12,000 or below 4,000, a fever of 39 or higher, age 75 or older, a bilirubin over 5, or a low albumin, and 2 of those need ERCP within 48 hours. Mild disease has no organ dysfunction and none of the moderate criteria, and gets an elective ERCP within 24 to 48 hours after stabilizing on antibiotics. And the key evidence is that ERCP within 48 hours reduces inpatient mortality and shortens stay compared with delay, and that benefit holds across all 3 grades, not just the severely ill. That data point is the answer to a common trap. The elderly woman who arrives with fever, jaundice, a white count above 20,000, a bilirubin of 3, hypotension that responds to fluids, and a dilated duct looks acutely septic, gets antibiotics and fluids, and 6 hours later her temperature is down, her pressure is solid, and the pain is better, and the temptation is to declare victory on the antibiotics, get an MRCP in the morning, and schedule the ERCP later in the week. That's the wrong read, because clinical stabilization on antibiotics doesn't equal resolved obstruction, since the duct is still blocked, and the antibiotics are only suppressing bacteremia while the closed space behind the ampulla persists, so as the antibiotic levels dip, the bacteria climb back, and she still meets high-risk criteria and needs ERCP within 48 hours, regardless of how comfortable she looks. Empiric antibiotics target enteric gram-negatives and anaerobes with a third-generation cephalosporin plus metronidazole, or piperacillin tazobactam, or a carbapenem in healthcare-associated or immunocompromised or recently instrumented patients, narrowed once cultures return, and when ERCP fails or the anatomy makes it impossible, as in a gastric bypass, endoscopic ultrasound-guided drainage and percutaneous transhepatic cholangiography are the rescues. Stone-driven cholangitis is the dominant story, but malignancy, anastomotic stricture, and stent occlusion produce the same syndrome through the same mechanism with the same decompression imperative, while sclerosing cholangitis and IgG4-related disease produce recurrent cholangitis from dominant strictures and have their own framework in the cholestatic liver chapter. So the acquired stone and infection side of the bile duct runs on one idea in 2 registers. The elective register is probability. ERCP is held behind a pretest threshold because the procedure has its own complication profile, so an abnormal liver test alone doesn't earn it, and the intermediate tier goes to MRCP, or endoscopic ultrasound, first to confirm the stone. The urgent register is cholangitis, where the obstruction itself drives a sepsis cascade that antibiotics can only suppress, so decompression is mandatory, and its timing scales with organ stress, within 24 hours for organ dysfunction and 48 for the rest, with clinical improvement on antibiotics never mistaken for a relieved obstruction. The next episode takes the structural and iatrogenic bile duct, the congenital choledochal cysts and their cancer-driving anatomy, the post-cholecystectomy bile leak and stricture, where the injury level decides whether a stent can work at all, and sphincter of Oddi dysfunction as it's now reclassified. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of 4 of chapter 27, and I'll see you in the next one.